matter, I guess, in terms of the recording. Oh, we have the recording starting. Cool. Just in terms of a few housekeeping things before we start, the session's being recorded, so if you don't want to be on camera, obviously you can turn that off. In terms of questions and answers, we're going to do those at the end, so if you want to put anything in the chat, please do. After we finish speaking, you can also use the hands function, but we probably won't stop in mid-flow. Thank you very much to Cath and Dan, who are former colleagues of mine, for running this presentation. So Dan is a very experienced orthopedic physio and now working in the specialist service, which we're going to talk about today. And Cath is an orthopedic researcher and current, I don't know what the right word is, but let's say PhD candidate in her final year. So they're going to talk a little bit about a project where we used physiotherapy. I say we, I wasn't involved, but I'm going to take some credit. They used physiotherapy to make a limb recon service greener, better for patients, and I don't want to give any more away than that because they've got lots of slides to share. But thanks very much for coming to talk to us in the evening. I really appreciate your time. Thanks to everyone for listening. I'll try and keep us roughly to time, but I think, yeah, you know, if we finish around 1:45, that would be ideal. And yeah, fire away, guys. Thanks so much for coming to speak to us.
Nice one. Thank you, Pete. And thank you everyone for listening in. My name's Dan, and I'm a limb recon specialist physio at the Royal London Hospital. And Cath, did you want to introduce yourself?
Yeah, as Pete said, I'm a research physio based in orthopedics at the Royal London, and I'm wrapping up a PhD at UCL in women's health and chronic pain.
Thank you. So yeah, this is a really nice collaboration piece between members of our orthopedic research team at the Royal London Hospital, which consists on this piece of work of 3 members, which are all physios by background, and our AHP limb recon team, which is myself and my CNS colleague Jade, and we are looking at basically our QI project was the environmental impact of how putting specialist physio within limb recon can develop. And we had a kind of unexpected effect within what we were looking at on how removing frames in particular was our biggest effect. Next slide, please. So we teamed up with the Centre of Sustainable Healthcare, and this was part of a Green Teams competition, which we fortunately were able to win it, but it was a bit unexpected against some real tough kind of competition and things that is going on with reducing carbon footprint in particular. But the Centre for Sustainable Healthcare really helped us explore carbon footprint, and in particular learning new skills on how you implement and address carbon footprinting and sustainability within the model of what we would classify as kind of clinical QI projects. But it was a wicked and great collaboration, and they are totally welcoming, and we were really, really grateful for that. So we next slide, please, mate. The limb reconstruction in particular involves what looks like this medieval torture device, and it's external fixation, typically for patients that have had really nasty injuries. So these are complex, often open, fragmented in pieces of bone, and it often impacts your skin, it impacts your vascular blood supply, it impacts your nerves, it has a overwhelming aspect of infections that can come from it. But although it looks very scary, it has it's a real positive alternative to the orthopedic management of traditional kind of how you would fix fractures. So that would be with internal kind of plates and screws or intermedullary nails in particular, as well as aspects of different forms of fixation. So basically this is used for when that isn't possible, and that's not possible because there could be too many fragments of bone or bits of unsuitable tissue, soft tissues and skin of where the bone has entered the environment, or it might be where using these devices, you can adjust, you can change the direction of bone, and using a bit of the body's magic, you can trick the body into growing back new bone using one of these devices as well. So correcting real big deformities. As you can imagine, it's a process that involves lots of time, lots of expertise, and lots of resources. Something that I think ultimately affects within the trauma population that we see at the Royal London Hospital. So if patients kind of fall within 3 brackets, they fall within having big, nasty trauma, they end up having a form of bone infection, or you can have bones that are slightly deformed, either congenitally or because fractures have healed in a slightly odd position and need correcting back to what a textbook would say. Next slide, please. So we talked about like kind of limb recon in particular, and the surgical management and the magic that can be performed by some of the excellent surgeons that we have at the Royal London Hospital in particular. But like I kind of alluded to, the resources are a lot more than just the surgery. So next slide, please. So the complex surgery is really time consuming, takes a lot of planning, is traumatic in its nature. But alongside that, you're putting on this big circular frame device, something external to the body, and you're going to have wounds that need managing. You're going to have a long process of aftercare. There's going to be managing issues that arise, such as like a pin site infection, let's say, or different infections and managements of how you modify plastic surgery that will go on top of this. So it's kind of orthoplastics management. We see, unfortunately, in the aftercare aspect, a lot of social problems in the community. We get patients with homelessness, loss of earnings because they're self-employed. It needs a lot of coordination from that aspect to try to point people in the right direction, as long as kind of, as well as their management in clinic. So you're managing x-rays, CT scans, you're being able to, this is all over a long period of months. So a patient will be wearing one of these circular frame devices for about roughly 3 to 6 months. If you're growing bone, it's going to be a lot longer. But the aftercare aspect of that is very multifaceted, is very multidisciplinary, is very resource heavy, with patients being able to have the surgery, manage at home, come back into clinics, be able to potentially have AHP-led clinics, etc., etc. So the rehab aspect of this is usually traditionally kind of outsourced to third parties. So these may be community therapists that will go out to people's houses, or people where you plug a patient with one of these circular frames into a standard kind of outpatient diary of where they're going to a gym. But it varies place by place. So most major trauma centres will have a limb recon rehab person, whether that be a physio or a kind of team. And that varies up and down the country as to what is on offer from a rehab perspective for these patients. But once a patient has had reached their kind of maximal recovery, so the bone has been consolidated, the fracture has healed, then the frame needs to be removed, and then they'll have a few appointments to come and see the consultants after that, and they'll usually be discharged from the service. So this is the type of the normal kind of pathway, if you like, of what is on offer for our patients at the hospital. Next slide, please. So looking at like the aspect of rehab, I started this role in May of 21, and you know that the aspect of rehab is going to help, but you don't quite know exactly in what way it's going to help. So it varies, and unfortunately it's a little bit of a postcode lottery, as I kind of alluded to, with being able to see people at home or experience, etc., etc. But the nature of rehab for this patient population from a socioeconomic and sustainability perspective is hugely underappreciated. The doctors, to speak quite frankly, the doctors can do the best surgery in the world, and a patient can be more disabled afterwards, not because of the surgery, but because of what we would classify as like a secondary complication. So these are when people can sometimes get contractures, which can be avoided through the right form of rehab. They would need more surgery because things aren't necessarily healing, or the milestones aren't being achieved because there are because the rehab aspect isn't being appreciated from for weight bearing, let's say. But the aspect of these patients would then fall into a socioeconomic pit of social care, more further surgery, chronic pain. There's you say it. There's things that could go wrong with the nature of this type of treatment in particular. So this is only one subspeciality of orthopedics, but it has an impact on people being able to have a massive increase in carers, let's say, a massive equipment burden, etc., etc. There's a cost that you can build and grow and snowball this as much as you like. Next slide, please. But ultimately, the rehab angle is appreciation of how patients can kind of tolerate this. And working within an MDT of what we have at the moment, you have I mentioned before, we have a lot of the homelessness, we have a lot of drug and alcohol addiction, unfortunately. There's a lot of psychological state and mental health support that is within there, whether patients have family and being able to manage, or if they're isolated. But ultimately, rehab is the key factor. And the honest question, there was a military paper done quite a few years ago on big complex injuries, so orthoplastics management of what we're talking about with plastic surgery and bony surgery, and should a patient just have their leg chopped off, and why not just amputate them? Why try to fix, because they're going to be in chronic pain afterwards? But the bias of that type of research is that the honest truth is that the money is funded for amputee rehab services and not funded for something like this within limb reconstruction specifically. So when you're talking about being able to provide the right kind of graded rehab, you're talking about holistic management, you're talking about having the right resources to be able to stop problems from occurring, manage their pain through exercise, which is a medicine on its own, and being able to change a patient's mindset, return to work, return to a decent level of function just with a cage on their leg. And this can be a level of function which is unlimited to somebody's kind of pre-morbid state. So what function they were doing kind of before they had their accident, which can involve running. It can involve jumping. I've had people go and climb. I've had a question on, can you go and climb mountains? Can you go and lift heavy weights? Yes, the device that is on the leg is designed to do that. And what that actually does is make the bone heal a bit quicker. But consultants will gauge based on a patient's willingness to engage in the process, and the rehab being one of those big angles of that, and whether they will actually do the surgery or not, and whether an impact on a patient's care is going to be there. And that's a resource dependent aspect that has been hugely underappreciated from before. So facilitating kind of frame removals comes into the aspect of practitioner work. And this is because the nature of these devices is adult meccano. It's getting your spanners out and being able to potentially fix things that might need fixing, or MOTing, as I like to call it, to some of the patients when they're coming into clinic. And angling the kind of discharge from the service and the length of time that they're spending in a frame is usually the biggest question. So then how this has evolved, next slide please, sorry, is looking at the different ways of how you can really impact on physio in limb recon specifically. And that can be from a kind of preoperative aspect of where, if there's time, so for those kind of elective cases of correcting deformities, meeting with family, visiting patients when they're on the ward, if they're waiting for surgery to happen, and consulting as much as humanly possible to make them aware. Post-operatively, you have an inpatient aspect to this of whilst they're still in the hospital, of joining the doctors on the ward round. We've got an enhanced recovery pathway that we run to try kind of reduce our length of stay for patients in the hospital, so they don't have to spend too much time in the hospital, which is good. We're running kind of teaching programs and developing services. And then the aspect of where this project comes about is the management in fracture clinic. So adjusting these frames and making sure patients can move their bone in the right way that we want them to, and there aren't going to be any complications of that. If there are kind of restrictions being lifted, you can get and you can input from a rehab angle very early door. And then an aspect of where I thought that this process was going to head down was looking at outpatient rehabilitation and being able to set up a clinic and be able to prove that by bundling these patients together, you can make a massive outcome. The realistic nature of that is that you're gauging something off of something that you can't manage or measure. So if you're looking at being able to go across multiple NHS trusts or community-based therapy, for let's say, or outpatient MSK across multiple different trusts, you can't. Unfortunately, there's a logistical aspect of not even being able to look at a patient's notes. So the outcome aspect is hard to gauge against, and something that we're working on trying to sustain and develop now. But then this practitioner aspect of learning new skills and working multidisciplinary, which isn't physio biased, it's practitioner biased, and shows the kind of nature of how physio can potentially, or any form of AHP, can learn new skills and affect things differently. But we can remove these frames. So we remove them in clinic when they're ready. That saves the surgical aspects that we'll come on and talk about. You can manage wounds. So as a physio and as a practitioner, we kind of do insight care and manage wounds. We kind of order the images, we adjust the prescriptions, we manipulate things. And this has a massive impact in future research. So this is a new role. We're looking to capture data. We're looking to do audits and quality improvement. We're being able to look at these different opportunities of presenting to you guys and how we can put something from clinical practice into a wider overall goal and collaborate to kind of push things forward. Over to you, Cath.
Thanks, Dan. I'm so glad that you did this first clinical bit, since it's your specialty. I'll tell you a little bit about how we put this context into sustainability. So our question when we started working with Dan in terms of trying to measure the sustainability outcomes of embedding physiotherapy within the limb reconstruction service was, what is the environmental impact of this? How is it that a specialist physio might affect the pathway? And we were expecting, of course, for there to be some obvious rehabilitation-based outcomes. However, things weren't as straightforward, and we'll find a little bit about that shortly. So the approach that we used is the Centre for Sustainable Healthcare's SUSQI approach, so sustainable quality improvement. The key of SUSQI is that it aims at improving health outcomes whilst reducing environmental, social and financial impact at the same time. And the integration of patient outcomes within the equation is really important to us. Since doing this project, we've done some stakeholder engagement with patients and clinicians at our site, and it has emerged that most of the resistance to projects that look at environmental sustainability are because people are afraid that sustainability gains are going to trump patient outcomes. So at the core of this project were patient outcomes. This is how we structured our process. So we set out our goal, our question, as I outlined. So we were interested in the environmental impact of physio and limb reconstruction. We then studied the system, so the limb reconstruction service and physio within it, looking at differences from let's say pre-Dan, physio within the service, and post-Dan, so once he was embedded within the team. Normally in SUSQI, you'd have an extra stage between the second and the third, which is designing the intervention. Our intervention was limb reconstruction, so we kind of did this retrospectively. so that we could swiftly move on to measuring impact, which involved further data collection and analysis of everything we'd done to that point, and developing some reflections. Overall, we collected data from 60 patients, 20 from the standard pathway, so the pre-DAN pathway, and 37 from the physio pathway. And we tried to exclude the COVID period, during which a lot of things were happening in the service that aren't representative of normal times. We collected resource use data from medical notes and from other sources as well. So we looked at consumables that were used. We looked at resources. So what did that look like in practice? You'll see a lot of the data points from the previous slide are things that you could pull from medical records and clinics, but we also had to get our hands dirty. Our colleagues from Centre for Sustainable Healthcare said, just itemize all the resources for each pathway and then just cost them. And you can imagine, if you're looking at things like surgery or clinics or wound care, etc., the list gets pretty long pretty quickly. And our colleague Becca had to go and weigh bags of waste in clinic and in theatres. So we looked at all kinds of things. We looked, say, within a theatre environment, we looked at cannulas, Goodell airways, anaesthetics, the energy consumption of the various clinical environments, so comparing theatre to clinic rooms. We looked at devices being used, medications, etc. And this is what we found. So and this is a summary of all the data that we collected, just so we don't bore you too much. So from an appointment perspective, we didn't note too much of a difference in terms of the number of MDT appointments that people were attending in the two different pathways. So there were around 8 to 9 MDT appointments per patient. The nursing appointments tended to go a little bit down within the physio pathway, but it wasn't a drastic difference that we thought was representative of the whole, probably more related to the sample size, which was anyway relatively limited. From an imaging perspective, we noticed that there was quite an increase in X-rays actually within the physio pathway, which we hadn't expected, compared to CTs, which remained pretty stable. Looking at the cases that we'd analysed, so the different patients that we'd analysed, we saw that there were a couple of people in the physio pathway who had very particular needs. And as Dan has explained, people within the limb reconstruction service can have really diverse histories and injuries. So we felt that that number wasn't really representative of the whole. So we looked at functional outcomes. But again, unfortunately, as Dan was saying, this is something that's quite difficult to collect because people, especially in the pre-DAN pathway, were being disseminated to all kinds of services, so outpatient physio, community physio, different trusts, etc. And it was really hard to get a concrete idea of how patients were doing within that pathway. All we managed to collect was a set of qualitative reflections within patients' notes that clinicians had collected, which did show a trend towards more positive functional outcomes for patients that had experienced more cohesive specialist physiotherapy throughout their journeys. But what really stood out for us was frame removal location. Now, we had not expected this to be a significant outcome. So if you see here in the standard pathway, 72% of patients were having their frames removed in clinic. This requires patients to go to theatre. It requires them, sorry, I think I got my words twisted there. So 72% of patients had their frames removed in theatre, which means having an operation and everything that that entails, versus only 27% having frames removed in clinic. When Dan joined the team, the trends reversed. So we're having more patients having their frames removed in clinic. And we asked why. We asked Dan and the team why, what's happening here. And it is down to the transferable skills that Dan was talking about, and the ability of AHPs and physios to work flexibly, learn new skills, and participate in MDTs at different points of the journey, not just necessarily in that rehab expected sector. So Dan was working together with Jade, our clinical nurse specialist, in outpatient clinics and offering patients the opportunity to have their frames removed there and then, rather than having to wait weeks sometimes, if not longer, for an appointment slot within theatres. So we are focused on this aspect of the pathway. We tried to understand what the differences were from an environmental perspective and having your frames removed in clinic versus theatre. So we looked at different aspects. We looked at anaesthetics, staffing, consumables, and estates and energy. With the help of the Centre for Sustainable Healthcare, we made the following calculations and projected our yearly carbon savings, which ultimately equal to about 12,000 miles driven by an average passenger vehicle. This is 19.7% reduction in emissions in a year. So you'll see here in the columns, we have two pathways for the theatre removal option and one for the clinic removal option. So in theatres, you have two options. You can either have IV anaesthetics or volatile gas, and you see the carbon emissions associated with each. You'll note in the totals that having your frame removed in clinic is much leaner in terms of emission than having it removed in theatre. And this is mostly to do with the fact that in clinics, we use far fewer consumables. So by consumables, I mean dressings, equipment, things like cannulas wouldn't be used in clinics and so on and so forth. The list is really long and it does have quite an impact. What we also noted, though, is that from an anaesthetic perspective, the use of Entonox in clinics, so patient self-administered anaesthetic gas, really has quite a high emission factor. So something to take into account, and we explored different avenues to decrease this. In fact, we did the same modelling with a different anaesthetic gas called Penthrox, which has a much lower footprint due to the active substance binding with oxygen instead of more pollutant gases. So a little estimation that could tell you how much more leaner our service could be if we introduced different gases into clinic frame removals. Obviously, we were working under this Centre for Sustainable Healthcare, SUSQI algorithm that doesn't just involve environmental outcomes. We've talked about patient outcomes. we did some economic modelling too. So again, looking at resources, similarly to what we'd done for the carbon costing, we calculated the expenditure for theatre removals versus clinic removals. If you look at the numbers in the different cells, and then if you look at the big number in the green box, you might wonder how bad my math is. So we were calculating the difference between the yearly cost for the standard pathway versus the physio pathway. We removed Dan's salary, and I know that it really hits home a little bit about how much AHPs get paid. But even after Dan getting paid, the service was still saving over 50 grand a year. So a 23% reduction in expenditure. So to summarize, our project showed that by making a small change in the team structure, we're able to make a significant economic have a significant economic impact and also significant environmental changes while maintaining, if not improving, patient outcomes. And the ability to prove these 3 points, as I was saying earlier, was really important to us in order to get stakeholder buy-in. One of the issues that we had when we first started this project was some criticism by senior members of our team that felt we were wasting our time, or if you like, putting resources, our own time and effort into non-priority areas, that we should be concentrating on patient outcomes rather than environmental sustainability. But proving the ability of improving different parts of the service at the same time was actually quite useful, and we managed to turn people's ideas around doing sustainability work around. It's also a project that's led us to think more broadly about what we can do in orthopedics at our trust and beyond, and at what stage those changes need to be implemented and considered, really. So we are doing a little bit of work with the UCL partners to develop a methodology to embed carbon measurements within orthopedic trials, so that when new interventions are embedded within services, there's already a carbon footprint attached, and commissioners and clinicians know what they are dealing with from a sustainability perspective. So what now? Well, since completing the project, we've shared our outcomes with service leads and at our departmental audit days, which has generated a lot of interest. So there are other small projects and ideas that are starting to take off. I've mentioned moving from Internox to Penthrox. This is something we're looking at, as well as looking at other particular pathways within orthopedics that could benefit from a SQI approach. We've shared our outcomes with the Limb Reconstruction Society, and overall I think we've made a case for AHPs within multidisciplinary teams and how they can contribute to more sustainable practices in unexpected ways. Little cheesy photo at the end that shows us when we got awarded our grant from the Centre for Sustainable Healthcare, and just to acknowledge Jade, who's our CNS, the one with the eyes closed, sorry Jade, and Becca, who also put a lot of work in this. So yeah, that's us at the end of the presentation. Please ask questions if you have any, or get in touch at any point if you're interested in finding out more about our work. Thank you.
Brilliant. That was amazing, guys. I was really inspired by the detail that you went into. I certainly do have a couple of small questions, but want to open the floor to others to see if anyone else had anything specific they wanted to ask.